Hello, and thank you for joining us today for this OncLive peer exchange on the topic of treatment of multiple myeloma in 2017 and beyond. As we continue to experience unprecedented progress in the field of multiple myeloma research, treating patients has become increasingly complex. Because of this complexity, evidence-based management of patients involves an art of medicine approach. In this OncLive peer exchange, a panel of world-renowned experts will join me to discuss how the latest science can be incorporated into the practical management of multiple myeloma in 2017 and beyond. My name is Dr. Keith Stewart. I am the Vasic and Anna Maria Pollock Professor of Cancer Research at the Mayo Clinic in Scottsdale, Arizona. Participating today on our distinguished panel are Dr. Amrita Krishnan, Director of the Judy and Bernard Briskin Center for Multiple Myeloma at City of Hope Comprehensive Cancer Center in Duarte, California. Dr. Sagar Lonial, Professor and Chair of the Department of Hematology and Medical Oncology and Chief Medical Officer at the Winship Cancer Institute, Emory University School of Medicine in Atlanta. Dr. Paul Richardson, Clinical Program Leader and Director of Clinical Research for the Jerome Lipper Multiple Myeloma Center and the R.J. Corman Professor of Medicine at the Dana-Farber Cancer Institute, Harvard Medical School. And Dr. Saad Usmani, Chief of the Plasma Cell Disorders Program and Clinical Professor, Department of Hematology, Oncology and Blood Disorders at the Levine Cancer Institute, Carolinas Healthcare System. Thank you all for joining us, and let's get started. First of all, we're going to talk a little bit about the classification of early myeloma and what constitutes indolent versus active disease. And there's been some changes in the way we approach that over the past year or two. And, Dr. Lonial, do you want to start us out, Sagar?
Yeah, so I think about 18 months ago, the Myeloma Working Group sort of redefined what it means to be symptomatic myeloma versus smoldering. And a lot of this came up because of concerns of patients with rapid time to progression being categorized as smoldering and observed. And so in addition to the traditional CRAB criteria that we have used for decades, we added 3 new criteria, and this includes greater than 60% plasma cells in the marrow, free light chain ratio greater than 100, or an MRI with greater than 1 focal lesion seen on the study.
And those patients now you would constitute as active disease and start treatment? Or?
Yeah, basically those are patients that had an 80% risk of progression to symptomatic myeloma within 2 years, and there's no reason to wait on those patients. I think the other piece about those guidelines is that the use of skeletal surveys alone in the context of patients that may be MGUS or smoldering is no longer considered standard, and patients need to have more advanced imaging, whether it's an MRI or a PET scan.
Well, since you brought that topic up of imaging, let's turn our attention to that. Dr. Richardson, or Paul, if I may call you Paul, tell us about what's known and what's been, because there's some recent studies that have looked at PET and MRI scanning in newly diagnosed myeloma. Tell us about those.
Well, thank you, Keith. I think that, as I would completely agree with Sagar, that the role of advanced imaging in this setting is now clearly established as a new standard of care to enhance our ability to detect early bone disease primarily. And I think certainly in that regard, the use of both MRI and PET-CT is clearly warranted. We've had a number of trials that have looked in various different settings at the value of advanced imaging, and clearly they've been useful.
And which one would you recommend? What do you do in your practice?
I frankly still use skeletal survey, but I augment it with PET-CT when clinically appropriate, and we use MRI. And as part of our protocol-directed approaches in smoldering disease, we usually use all 3.
Now, the French and your group, I think, have been doing a study where you do PET MRI scanning, and if I recall rightly, there was some evidence that could be predictive for outcomes once you start treatment?
Yes, in the context of active disease, the imaging part of the study has been actually led by our French colleagues, and primarily in that setting they've been able to demonstrate that it adds a level of sensitivity to MRD assessment, minimal residual disease assessment, that actually correlates with outcome. So we have the concept of MRD assessment including imaging.
What other, Amrita, what other tests need to be done in a patient that we're working up that help risk stratify the patients?
Well, I think certainly we can't ignore the role of cytogenetics and the biology of each person's myeloma. And I think your group's done a lot of work in terms of personalized medicine. So we're going to get even more sophisticated about that and really being able to predict who is going to have more biologically aggressive disease.
So if you're in community practice, what do you think is the minimum level of testing that should be performed?
I think targeted FISH analysis is really widely available. And again, I think it's important that people know their lab and that they are truly doing targeted FISH on the plasma cells so that they're comfortable with those results.
And are there any specific indicators that would send warning signals to the physician that they should be aware of?
I think the things that we traditionally consider high-risk cytogenetics, for example, 17p deletion, certainly would be one that would put you at cause, and think about in a patient that you still think is asymptomatic, you would certainly have a higher degree of closer monitoring.
What about the LDH? Is that something you use?
I do use it. I'm not sure that in the very early stages of disease it would be as useful, but I think it's an easy, widely available test that you can certainly follow, and certainly changes in that would be a quick, easy marker to warrant further workup.
So it sounds like we're sort of beginning to start thinking about treating myeloma patients a bit earlier in the course, slowly defining those who are going to progress quickly. And do you treat smoldering myeloma, Saad? What's your approach to that?
So generally, we like to follow the Mayo Clinic risk criteria. I knew you'd say that. But for the low-risk smoldering myeloma patients, they essentially need to be followed very similar to the MGUS folks. So maybe checking their labs once a year and following them. For the intermediate risk, perhaps.
And just for the audience, so just low risk being what? Tell me what low risk looks like.
So it has to do with there are criteria around M spike being 3 grams or higher, bone marrow plasma cytosis being 20% or above, and I think the light chain has to be abnormal. Involved versus involved over 10, if I remember correctly.
Greater than 8.
So
this was a test for you, by the way.
So did I pass?
Sort of.
I mean, I think
So
it's a.
I think.
Go ahead. Sorry.
So yeah, I mean there are several criteria out there, right? So there are, I think the last time I checked, 11 different ones, including the Spanish myeloma criteria, which includes the immunophenotypic flow abnormalities, the aberrant ratio of 95% or more. But I think for more practical for community doctors out there is probably still the Mayo Clinic criteria.
Yes.
And the low and intermediate risk folks still probably need to be followed. Just with labs. Maybe the intermediate folks need to be followed twice a year with labs. The high risk